you're not affected by a very nice gala that we had last night. Our talk is about the angio-OCT interpretation and possible pitfalls. Now, what has changed? What has revolutionized the way that we deal with medical retina patients these days? Is it the drugs? No, because we have the same drugs for the last few years. What has really changed is the imaging, the way that we see these diseases. And exactly, we had in the past the time domain OCT, then the spectral domain OCT, and today we have swept source OCT, and this gives us the chance to go from the lines and the raster lines to the 3D imaging, even reconstruction layers like the retinal thickness maps. And now we have the OCTA, the OCT angiography, which gives us the chance to have images at different levels of the retina, of the macula actually, and know exactly where the lesion is and how it responds to our treatment. And we can combine these images with the ANFAS OCT, so that will give us all the information that we need about the place, the extent of the lesion, and the type of the lesion that we are dealing with. Now, where does that actually help us? Let's go to wet ARMD, because actually the OCTA is our main tool for monitoring and treating these patients. It's not that helpful in diabetes or vein occlusion, but in wet AMD is a very, very interesting examination. And why is that? Because up to today, we could see the exudative status of the disease when there is fluid in the OCT. That doesn't mean that the disease was not active. Today, we can check the neovascular status. We can actually see this membrane. We can actually see how it responds to treatment, if it's getting better for the treatment, from the treatment, even if there is no fluid in the OCT. And this can lead us to new treatment protocols. Because as you can see in this slide, we can now see with the angio-OCT if the membrane has a reduction in the size, in the flow, if the vessels are thickened or thinned, if there is a shrinkage of the membrane, or if it changes shapes. And here you can see exactly how this membrane, the neovascular membrane, responds to treatment. 1 month after the anti-VEGF injection, you can see how the membrane is not that active, how the vessel walls has shrinked, and how the flow rate is reduced within the membrane. And again, 1 month after the second injection, it's nearly gone. And 2 months after the third injection, there's still some remnants, some remnants of this membrane. And actually, you can see here how the size is reduced after the injection treatment, how the flow is reduced within the membrane, how the vessels gets thin, and how it changes shape, actually, after treatment. And we have something that we call angioanalytics that help us actually measure this membrane, and we know the exact extent of this membrane, the height, the diameter, and the area that it covers, which is really helpful also in patients with long treatment duration, that there are areas of atrophy that happen usually near the membrane. When this membrane covers a very big area in diameter, we expect after some years of treatment for atrophy to emerge from the edges of this membrane. Now, the same stands for the ANFAS OCT. As we can see, the size reduction, and we can monitor these patients both with ANFAS OCT and OCTA. And exactly this is how the anti-VEGF works. When we inject a patient with an active membrane, the drug starts to work about 24 hours after that. We knew that, of course, when we did, for example, injections in patients with neovascular glaucoma, that in the first 24 or 48 hours, the iris neovascularization disappears. Now, in this case, you see here how the membrane starts to get smaller within 24 hours. The peak of the drug efficiency is about 7 days after the injection, and 1 month after the injection, it starts to form again. The flow rate starts to grow within the membrane, and again, after the second injection, in 24 hours, it starts to get smaller. So how does anti-VEGF work? The eye has high concentration of VEGF within the vitreous cavity. And this high concentration of VEGF helps this membrane get active, and it's the actual the actual phase of the disease. But when you inject the patient 24 hours after the injections, the VEGF concentration is getting lower and lower within the vitreous cavity. In 7 days after the injections, a very rapid regression, and the VEGF levels are extremely low within the vitreous cavity. 1 month after the injection, although the VEGF concentration will start to build up inside the vitreous cavity, thus leading us to a regrowth pattern of our membrane. So what that tells us actually, because these are the therapy phases and how our treatment works. And what we have found out with OCTA is that we were doing the right thing, but we didn't know why. We have been arguing for a long time that treat and extend is a better protocol of PRN. And we believed that, but we didn't know why. And now this has been proven. Because with the treat and extend regimen protocol, you actually phase the disease in a status where you don't have fluid in the OCT, you don't have an exudative phase, but the disease is still there. It's the membrane that's in the back of the choroid and gets dry after each injection. So yes, treat and extend is better than PRN, because with the PRN regimen, we had to deal with patients who had a severe reduction in the visual acuity, severe regression of the disease, subretinal hemorrhages, etc. So treat and extend is better, and we have proved it now with the OCTA, because we treat the disease in all its phases, the exudative phase or the neovascular phase. Instead, with PRN, we treat only the exudative phase, and this, in the long run, will give us worse results. We talked about the reactivation of the membrane. It helps us, the OCTA, to do an early diagnosis in patients that have very, you see, the patient here has an active membrane. There is no exudative phase, there is no fluid, although you have to monitor this patient, because you expect that the moment that this membrane will get more aggressive, subretinal fluid, the exudative phase, will sometime appear in the eye of your patient. So you have to be aware of that, have an early diagnosis, and treat the patient. And you can see actually, OCTA actually images the very high flow rate of the blood inside the retina, and depending on the shape that we have from the images, we have given some names in these patterns. So we have the C-fan membrane, the umbrella or medusa, loops or pipes, if our new vessels have a similar pattern. The thing that helps us also with the OCTA is that we have given rise to some new names and new membranes that we didn't know that exist in the past. First of all, we have the quiescent membrane. What is the quiescent membrane? The quiescent membrane is a membrane that has, in different consecutive visits, zero exudative phase. There was fluid in the past, we treated the patient, and it's dry in several consecutive visits. Although there is still membrane in the choroid that just does not produce any fluid. In these cases, usually the FA is without leakage. The ICG may give you a hyperfluorescent plaque in the late frame, but the main test, the main examination to confirm the quiescent membrane is the OCTA that will actually show you the membrane. even if there's no fluid in all the visits that the patient has in your private office. Sometimes you have these disruptions in the RPE. We talked about it yesterday. This is not PEDs. These are erosion signs or double layer signs when it's IPCV, and it shows us that there's something down here that's creating this slight elevation, and what's down here, this quiescent membrane that does not produce any fluid. Is there any significance to monitor that? Yes, because actually 5 out of the 19 patients in studies that took place developed the exudation, and we have to closely monitor these patients because sometime the disease will reappear. And actually, a very large proportions of these quiescent CVs, of these quiescent choroidal neovascularizations, cover the area that are spared from atrophy in the long duration of the disease. Another new membrane is what we call the nascent choroidal neovascularization. And what's that? This is a treatment-naive eye, so the eye never had injections, but there is a membrane. It's been there for up to 15 months. We have this number from many studies, and there is no exudative phase at all. The patients in the past didn't have the membrane. Sometime they developed this nascent membrane, which is here, like this patient again. Again, we have these disruptions, these disruptions in the RPE. You can see here this small nascent membrane. And actually, what we have found out is that it alters in shape, and it may not reduce the visual acuity, but it can cause metamorphopsia, and it reduces the sensitivity of the retina, which can be a problem for many patients. We've seen in some eyes that we expect sometimes when we inject the one eye to have an effect in the other eye too. And we have seen that mainly in diabetic eyes, when the reduction of the CMO in one eye was followed by a slight reduction in the CMO in the other eye. Unfortunately, in the nascent membranes, this is not the case. You can see after injections in the good eye, the nascent membrane has actually, it's actually enlarged, I would say, as you can see over here. So yes, we have to closely monitor these patients because if these membranes produce fluid, then we must treat them for the exudative phase. It doesn't mean that everything that lights up in the OCTA is a membrane. Again, in the OCTA, as in the classical angiogram, we have some artifacts. And this is mainly, if you remember the window artifacts from the FA, we have window artifacts in the OCTA. The atrophy of the retinal pigment epithelium may appear like an area of neovascularization in the OCTA. Sorry about that. Here you see these areas of atrophic RPE. They project in the OCT angiography as neovascular membranes. Of course, they're not. That's why you have to be very careful in which level you are and which projection you have in the OCTA. This patient has a Stargardt disease. It's obvious from the autofluorescence, but you can see when you do the OCTA in an area that has such an extent of an atrophic macula, you see the choroid vessels, they are white. Actually, in the OCTA, the choroid vessels should produce a dark image, like here, which is the normal area of the RP. Because you have this huge atrophy, this whole area of the Stargardt patient disease looks like there is something active, or at least some big vessels that have a very flow, they have a big flow rate inside them. That's not true. It's because you have this huge atrophy, these vessels look white, and exactly in the area that transforms from the problem, from the atrophic area to the healthier retina, you see that the choroid vessels start again to look black on the OCTA. So we have to be really careful sometimes in order not to interpret atrophic areas as active vessels. The same stands for this patient, which has an atrophic area, and it projects in the OCTA as a possible membrane. It's just because you had your slab here, so you have to be very careful where you put your slab in the machine. Again, when you have a tissue with high hyperreflectivity, it may project in a different level. Here you have a vessel in the superficial capillary plexus. It's superficial, but because you have this area with high hyperreflectivity, sometimes it may project over here. And if you put your slab over here and you're not sure that this is projected, you may mistake this area for something active. Again, it's the same thing as I told you. This is a patient with acute idiopathic maculopathy, and you have this tissue with very high hyperreflectivity, so it projects in the outer retina. This is the deep capillary plexus. It projects in the outer retina like something is there forming. Of course, that's not true, and if you carefully see the en-face OCT, you will know that this is just a projection and not something active. The same stands with a patient with CSR. You see here, this is a patient with CSCR, and because we have our slab, here in the atrophic RPE, we have a projection in the OCTA of an active membrane, which is not, of course, the case. The same, it may project also in different levels as the choroid. So we have to be very careful with where we put our slab segmentation when we try to interpret the examination. Again, some projection artifacts. But also we have some problems that are not artifacts. The problems is that because the technology follows the blood flow, we don't actually see the vessel walls. So we don't know if there is an actual reduction in the flow or a vessel disappearance. So we cannot predict exactly how the membrane will react. Also, when you have a low rate flow, you have a problem. This is a classical fluorescein angiogram, and this, of course, is a macroaneurysm. Everybody knows that. But when you try to take an image of this macroaneurysm with OCTA, you will see that there's nothing here, and that's because the flow, the rate has a very, because the blood has a very low rate flow. And the same stands with the polyps. Here you have a patient with a visible polyp here, but when you try to take an image of that polyp with the OCTA, you will see that there is nothing here, again, because of the very low rate flow within the polyp. Concerning the myopic CMVs now, I'll be very quick about that. You know that we have two types, the one emerging from the atrophy and the subfoveal. Actually, the myopic CMV is the only CMV that can be active with no exudation at all on its course. So also it's the membrane that OCT, the classical OCT, doesn't help you, and up to now, if you wanted to be sure, you had to do a classical fluorescein angiogram. And also, these myopic CMVs can lead to huge metamorphopsia of the patient, even with the slightest of blood or fluid. And actually, sometimes the classical OCT is not helpful because you don't know if this is an active lesion or not, although the angio-CT will clearly show you the membrane that is active. Usually, the myopic CMVs are very small membranes which react very well to treatment. They actually need few injections, so the patients with myopic CMVs are usually the happy ones. And this is a case of choroidal neovascularization on angioid streaks without findings in the FA. This is very common, and this is where the OCT has and lies its strength in the new multimodal imaging wall that we have for AMD. This patient has angioid streaks. You can see them. He had a hemorrhage in the left eye, so he had an active disease in the left eye. That's obvious. In the right eye, although the angioid streak thankfully for this patient, does not go through the foveola. The classical angiogram shows some staining only. There's no actual leakage here. And the OCT is normal. It just shows these disruptions that we talked earlier. So somebody should be a little bit more careful with this patient. And exactly when you do the OCTA, you will see that in this patient that doesn't have any leakage or fluid in the OCT, he does have a membrane in the choroid, which is a very common finding in people with angioid streaks. This is the membrane. You can see it here. You can see that there was no fluid in the OCT, no leakage in the FA, but the membrane lies here waiting to strike the patient visual acuity on its first given chance if we don't do anything about it. To be honest, I wouldn't treat, of course, a patient with a membrane without active leakage or active fluid, but it's something that it's under debate in the future. I don't know how we're doing from the time point of view. I think we're not doing very well. Okay. So I'll stop my presentation here. Thank you very much for your attention.
Thank you very much, Trifon. I know we're standing between you and the lunch, but we'll leave at least 5 minutes for some questions. We covered a lot of areas, so I'm sure there will be questions. Very good. Yeah, I shouldn't be so. Anyway, any comments from the panel?
I have a question in regards to CRVO, which was it's actually it was disturbing to me the fact that you showed us a patient, I believe, correct me if I'm wrong, ischemic CRVO treated with anti-VEGF, stopped anti-VEGFs, and developed rubiosis about a year after the last anti-VEGF. I mean, that's really disturbing. What I do is I usually monitor them closely for a neovascularization of the iris for a couple of months or so, but then if they're beyond a certain point, let's say, following the 3-month rule, which I'm not sure it's actually right now after anti-VEGF, about a year, it's alarming. I mean, that's dangerous, I guess.
Yeah, I think that is also alarming. So we only really became more aware of this when we looked at our data and discovered that seems to be the pattern. So I'm worried that we are delaying this happening, and we might miss it if we discharge such a patient. So that's why I was suggesting, if you are getting to the end of doing your anti-VEGF, the vision's not very good, maybe you need to make that decision, is it an ischemic eye or not? So maybe that's the time when you do your fluorescein, or you just have a very careful look, is it ischemic? And if it is, well, then maybe you shouldn't be discharging it quite so quickly, but if it isn't, then you're much happier to do so.
Well, talking about the ischemia, James, again, I think that there's a discrepancy between how you measure and quantify ischemia. Now you are using, I noticed most of the pictures were optos.
Yeah.
So it's completely different, the number of ischemic areas that we used to calculate before.
Yeah, so I'm afraid it's a bit subjective. Yeah. How do we measure it? Yeah, absolutely. It's much more than 10 disc diameters. I mean, you can take 100 disc diameters if you look at the optos closely enough. So I don't really know the answer to that, but you have to look, by looking at the whole picture, you certainly can get how much. But exactly the correct amount of how much, I'm less clear about that.
Yeah, the other thing is that we used to say that in order to carry out PRP, you should really see NV. Now, do you do prophylactic laser when you see extensive areas of ischemia?
Well, that is uncertain. I totally agree. So, but if you don't do your prophylactic PRP, then you probably should follow them up, because maybe they're going to get the rubiosis. And then how long should you follow them up? I haven't got the answer to that. Yeah.
So, I guess patient's compliance does play a role as well, doesn't it?
Sorry?
Patient's compliance and how well.
Yes. So that's the issue is, well, if you don't want to follow them up, or the patient doesn't want to come, would it be advisable to do some PRP if it is definitely ischemic? Yeah. I can't give you the exact answer for that. Some of these patients may be fine, but others won't be. So you've got to at least warn them, I guess.
Of course. Okay. That's great. I would like to thank all the speakers. Just a couple of announcements. Now, we have one more session, and we left the best for the end. Now, we have OCT and glaucoma and OCT and anterior segment, which is not usually covered in OCT courses, so you shouldn't miss out this. But in addition, we have the session that we left from yesterday, the oculoplastic one. Now, we are very privileged to have with us one of the best oculoplastic surgeons in UK, Raghavan Sabath, in Leicester. And actually, we are even more privileged because he brought with him his best fellow. So I'm sure he has fascinating cases to show us, so we shouldn't miss out. They will cover the section just after the lunch. So enjoy your lunch now. Thank you.